we'll go ahead and get started. This is the fourth of our four scheduled webinars with our friends at HPIO. Haley and Amy are back this morning. We're just going to do a brief recap of some of the material that we've had in the previous three. And then we reserved the majority this time to answer any questions that you have, any outstanding questions, any clarifications that you would like to ask for or request or talk about as we come up on the due date of the committee assessment and plan in about 2 weeks. So we really want to be able to answer any questions, any remaining questions that you have, or just specific questions that you have with your situation, your plan, your data, whatever it is that may be. We want to be able to hopefully that you feel confident leaving this final webinar with all of your questions answered. So as I said, we'll do a brief recap of some of the material. We'll kind of clarify some things along the way, some questions that have come up over the last week or so, and then we will turn it over to all of you to ask your questions. So I will welcome Amy and Haley. Good morning. Thank you for joining us again.
Good morning. Good morning. Thanks, Chad. And thanks to all of you. Chad did a fabulous intro for what this session is going to be, so I'll be very brief at the top, but just want to acknowledge that this is the last webinar that Amy and I get to be a part of and engaging in this work with all of you. And we're so thankful for the time that you've spent with us and the hard work that you've done on your plans. You know that we've been working in partnership with OhioMHAS to produce this technical assistance for you all. And Chad gave us a really great look into our agenda today. First, we're going to look at some of the resources that you have available to you. We just want to recap this for you so you know where it all lives and what you have access to as you continue finishing up your plans. We're going to do that brief recap of some high-level content from previous webinars, and then we're going to spend some time in open discussion, problem solving, addressing the questions that you have. Okay, so as far as resources go, here's a list of the CAP Technical Assistance webinars that we've produced over the past several months. Back in October, we talked about how to elevate equity and address disparities through your CAP. In November, there was an explanation of SMART objectives and sort of a brief look at the indicator menu. And then in December, we did a deeper dive into that indicator menu and talked all about data sources to inform your SMART objectives and your overall work on the CAP. All of those webinar recordings are available to you. They're available here on this community planning page on the OhioMHAS website. I am going to drop this link right into the chat so that you all have it handy. I'm sure you've seen this page, but this is where all your technical assistance materials live. So you can revisit those webinars at any time. They're there for you. If you scroll down a bit on that same web page that I just sent you the link to, you'll see a header that says 2023 to 2025 Community Assessment and Plan Templates. And beneath that header, there are more technical assistance resources that you'll have access to, including these two fact sheets that Amy and I produced for you all. One is on elevating equity. One is on SMART objectives and standardized indicators. These are sort of a recap and a written spelling out of the content from the first and the second webinar. So if having a paper copy in your hand is easier for you to digest, this is where you'll want to turn. And then finally, of course, posted on that same site is the standardized indicator menu. This should be a very helpful repository of indicator options available to you for your SMART objectives. So we hope that you've taken a close look at this, and we're happy to answer any questions that you have about it or questions about data sources that you have today. All right. With that, I'm going to take us into our brief recap, and I'm going to start with the equity webinar that we did back in October. Just a few high-level things. So during this webinar, we discussed how equity is a cross-cutting priority in the conceptual framework of the CAP, which we see here in that yellow bar, equity and cultural competence. The goal here is to keep equity front and center in the assessment and the plan so that our long-range impact and our vision can be achieved. They hinge on elevating equity. The long-range impact is that Ohio has a high-quality mental health and addiction prevention, treatment, and recovery system that is effective and valued by all Ohioans. And the vision is to end suffering from mental illness, SUD, and problem gambling for Ohioans of all ages and from all families and communities. We defined health equity this way, that equity is achieved when all Ohioans have the opportunity to attain their full health potential, and that equity is the absence of socially unjust or unfair disparities in access to services, quality of services, and health and behavioral health outcomes. In this webinar, we also covered some considerations for embedding equity throughout the CAP process. These are the considerations for the assessment. We'll also look briefly at the ones for the plan. It is certainly not an expectation that all of these considerations are happening perfectly during this CAP process, but these are components of equitable assessment and planning that can be built towards over time. So first we see engagement of community members and partners. Equitable assessment includes engaging a broad range of community partners through all phases of the assessment and ensuring that those community members are included in decision-making and that they have shared decision-making authority. Next is collecting the data for the assessment. That data, whenever possible, should be disaggregated, both in the quantitative data that you might find in the standard indicator list, but also in qualitative data. And qualitative data is a great way to fill gaps when the quantitative data is not available for disaggregated groups. We also, like I mentioned, want to be creative in filling those data gaps. Quantitative methods like focus groups is a great way to do that. We'll also talk a little bit about how to do this in some smaller board settings. Things like pooling years or grouping counties together can be a way to get to some disaggregated data when the numbers are too small in one county or for 1 year. And then we want to explore the root causes of the disparities that we're seeing in the data. Asking questions about what's driving those disparities in our social context, in the social drivers of health, is a more effective way to reduce disparities, knowing what's causing them upstream. And then finally, we want to use the results of the assessment. We want to highlight the strengths and the challenges and the disparities that we're seeing, flagging those key disparities when we talk about our community challenges, and then sharing out the findings of our assessment with the community, particularly the partners that were engaged in the process, to increase transparency and to allow for accountability in our action to address the things that we identify. We also covered some considerations for embedding equity in the planning process, which is, I know, where you guys are now. Again, the expectation is not that all of these things are perfectly happening right now, this month, but that we're aware of these components of equitable planning and that we're working towards incorporating them. First, again, is engaging community members and partners in these same ways, engaging a broad range of partners and including them, building them into the decision-making process when it comes to identifying priorities, setting targets for SMART objectives, things like that. Second is prioritizing issues, the process of the prioritization. We want to be using our assessment findings to identify not only our priorities, but our priority populations, including those groups that have the greatest health challenges that we see in our disaggregated data from the assessment. This is also our opportunity to address the root causes of the disparities that we identified in our assessment. If we were able to go upstream, look at some of our social context, the reasons why we're seeing the disparities we're seeing, we can develop priorities and SMART objectives related to those in the plan. That's an optional piece, but it is there for us to use. And then we can develop SMART objectives, right, to monitor our progress. This is a key component of the plan. And we want to be monitoring progress not only for the board area overall in the things that we're prioritizing, but also for the priority populations identified in that disaggregated data. Again, equity smart objectives is an optional piece in the CAP this go round, but is certainly an important area and something to build towards. Finally, there's implementing the activities of your plan. After the plan is submitted, there's work to be done in addressing the priorities identified. And so a consideration here is tailoring those strategies, those policies, programs, and services that you've identified, tailoring those to the priority populations with the greatest need, making sure they're culturally and linguistically appropriate for the groups with the greatest challenges. And then there's also, of course, allocating resources to fill gaps and being strategic about how resources are allocated when it comes to implementing those strategies across the board area. All of this content, the 2 slides that I just shared, are sort of the backbone of the fact sheet on elevating equity, that technical assistance fact sheet. So if you want to dive a little bit deeper into this and see a little bit more of this built out, you can definitely head there. And I'm going to post the direct link to the fact sheet in the chat as well.
And I want to stress as well, and we can answer additional questions of this here in a few minutes, but we want to make sure that we address equity as more than just race, and we address disparities. It could be amongst many different demographics. So it could be older adults. It could be adults that or families that live in rural settings. So you could have all of your concentration of services in the southern part of your county, but those that are accessing it the most live in the northern part of the county, and then transportation is an issue. So you have veterans population, women, female populations. Equity isn't, and disparities isn't always centered around race. It could be poverty. I mean, it could be education. It could be unemployment, underemployment. So there's a lot of different things that can wrap itself around this equity conversation that we're trying to have. It's not just race. So we just want to make sure that we're clear about that as you continue working through your planning process.
Absolutely. And you'll see in that fact sheet and in the template itself, a long list of possible priority population options for you to sort of think through and consider as you're grappling with this. Who are the groups in your board area that have the greatest need on each of the priorities you've identified? Okay, and with that, okay, I'm going to pass it off to Amy, who's going to take us through the next webinar.
All right, good morning, everyone. Good to be with you one more time. I'm going to recap some of the high points from the webinar number 2 and number 3. And I'll go fairly quickly, but we are definitely going to have time for questions and discussion. So be thinking of things you would like to ask about. So in the second webinar, we talked about the distinction between outputs and outcomes, and how it's generally easier to measure outputs, and the goal is to get towards more measurement of outcomes, which is really getting to the heart of what is the result, what is the impact of what we do. And so the CAP plan template is designed to kind of prompt and help us build towards that capacity for measuring outcomes. Outputs are also important and good to measure, but we also want to be focusing more and more on outcomes to the extent possible. Next. And we talked about how your assessment may identify a wide range of challenges in your community. And you probably not realistic and probably not efficient or effective to address all of those challenges in the plan. And so we talked about how you kind of prioritize and narrow down from what is identified in the assessment to what are the specific topics and indicators that you're going to focus on in your plan. Next. And of course, we talked about SMART objectives, which I know all of you are now very familiar with. And many of you were already very familiar with SMART objectives. So here we're talking about being specific and measurable when we look at those outcomes, and that's where the indicator and the data source come into play. Those are those columns in the plan template. We also want objectives to be achievable and realistic, and kind of striking that balance between what is achievable and realistic, also being aspirational, and that this is where we set targets. So saying in 3 years, we want this data value for our indicator to be X. And then the last element here is time bound. So that's just being specific about what's your baseline year or whatever time period your baseline data is coming from, whatever that most recent data is coming from, and then how far out are you planning? Planning 3 years out, 5 years out. What is the year for that target for the outcome that you want to see? All right, and then webinar number 3, for those of you who were there, should be more fresh in your mind. So we did that in December. And next slide. Here's where we talked a lot about the standardized indicator menu. That's that Excel sheet. And it is posted on that page that Haley referred to. I know Chad has sent it out a few times. We have continued to update it and improve it. So the December version, which is the one that's posted on the website, is the best one to use. So if you had an earlier version from Chad, I encourage you to go to the website and pull down this most recent version. Next. So this indicator menu is really meant to be a resource for you to get to real data. It is aligned to other things that are happening in the state, to hopefully help with that collaboration with your local health department or other partners in your community. It is not required that you're using indicators from this list. It is not everything. You might have better data in your local community or just be aware of something else that gets at something you want to do in your plan. Next. And then we went through this example of work that we've been doing with MHRB, of Clark, Greene, and Madison counties, and just how, we sort of took these assessment findings, then we looked at the indicator menu to start to zero in on what are some indicators that they can be tracking over time to get at the issues identified in the assessment. Then there was sort of the reality check, right? Looking, can we get the data? Sometimes we can get the data, sometimes we can't get the data. And so new data collection is required. Sometimes things are a little fuzzy or there's a data request involved. Maybe you're waiting for some data from a hospital in your community or something like that. So that was kind of that middle ground that we were working through. So that was just an example of what that might look like. And next slide. And then we did a demonstration of some data websites. We had some special guests. We went in and pulled some data from these sources. So if you missed this webinar and you're interested in these sources, I encourage you to check out that recording.
And I'll let you all know, that's the end of that. As Amy was going through those slides, I dropped the link to the second technical assistance fact sheet in the chat, which is a much deeper dive on indicators and SMART objectives. You check that out as well.
Yeah, so now we want to use the rest of our time on this call today to go over your questions. And we had a really good question that came up at the end of the last webinar on our evaluation survey. And so we wanted to start by addressing that. So as I talk about that one, please be thinking about other just questions, problem solving, comments, whatever you would like for us to talk through today. So a question that we got was, what about boards with small population sizes? Like it is more challenging for boards with smaller counties to find data. And part of that is just a reality of numbers, right? Sometimes, particularly when we're talking about surveys that are done, like national and state surveys that are done, they're just not always getting a big enough sample size that they can say anything with confidence about counties that are smaller. And that is just an unfortunate reality. So we have some suggestions here for things that smaller counties can do, and would love to hear from other smaller board areas on the call today if you have other suggestions of things that are working for you. So the first is this idea of pooling your counties together, which obviously only works for multi-county boards. But this idea of pooling is just the idea of like strength in numbers. And so you can pool counties together. That'll give you bigger numbers that are more stable over time. You can pool years together. So you'll see that in the county profiles from OhioMHAS, for example. There's some pooled year data. Pooled year data can be great for your assessment. It's not fantastic for SMART objectives because then you maybe have like a 2 or 3 year time period. It's not great for monitoring change over time, but it's great for assessment purposes. And then another thing you can do is pool together outcomes even. So in the example we had from MHRB last time, we talked about pooling together suicide deaths and overdose deaths and kind of and alcohol related deaths as sort of behavioral health related deaths. So anything that you can do to increase numbers, kind of pool your numbers together will help you with looking at stability of numbers over time. Because you may have noticed, like if you're in a rural county and you're looking at your number of suicide deaths, it might bounce around a lot just because of those small numbers. And so doing some of this pooling might help you with your trending over time. The second thing here is just, going to that standardized indicator menu. There is a column that indicates if local data is available. So there definitely are sources out there that have county level data. Just a few examples here, but school districts are a fantastic source of data for that kind of for really local, right? Because you can get school district and school building level data. There's a lot of good stuff on the Ohio Department of Education website, or, I'm sure many of you have really good relationships with your districts and might have access to additional data that they have. And they disaggregate things often. So it's a great source of equity data when you're thinking about your children and youth population. And then some of the other ones here, ones that we demonstrated on that December webinar. Next. And then of course, sometimes, you just don't have the data that you wish you had. And so as many of you already do, thinking about sharing those data collection resources, since the local health departments have to do their CHON-CHIP, hospitals have to do their community health needs assessment and implementation strategy. AAAs are doing similar work, your area agencies on aging, family and children first councils. There are a number of entities that are doing this kind of assessment and planning work. And as we put that menu together, we were mindful of what are they supposed to be measuring so that you can find that common ground. Like, is everybody focused on chronic absenteeism? Okay, let's work on that together. Well, that's easy data to get because that's school data, but there could be other things that you could be working on with other partners in your community to collect the data. Building provider capacity to collect data. So I know some of your providers are doing different types of client satisfaction surveys, functioning surveys. And so kind of working with your providers to get all of them or most of them to be using a standardized survey instrument that you can then kind of aggregate across providers in your counties would be great. Hospital data. Hospitals, of course, have data. Not always the easiest to get, but building those relationships with your hospitals and health systems so that you can request that data, and just being really clear, you are not asking for identifiable individual level data. There's no HIPAA violation here. You just want aggregate trend data for the community. And then finally, encouraging, working with your districts, encouraging them to participate in the OES survey or the YRBS or some other kind of school-based survey. Ideally, the same one across different districts in your board area so you can roll that data up. Okay, I'm not going to stop talking. One more thing. Okay. And just there was also a concern about, well, what about statistical significance? Our numbers are small. We can't get to statistical significance. And just want to reiterate that, really the purpose of the SMART objectives and the CAP plan is it's all about improvement, continuous quality improvement, progress over time, having those shared goals and community accountability with others in your area, and then just that transparency, showing the community these are the goals we're working towards, and here's how we're doing. We need your help. This is not academic research. You don't have to have statistical significance, and it's not about judgment and punishment. Chad is not going to be looking for, do you have statistical significance in your progress reports? And if not, you're in trouble. That is not the purpose. Okay, now I'm going to stop talking. So we want to open it up and just see what kind of things you're running into, questions, or maybe a fantastic solution you've come up with that you want to share with others.
Well, and before we start, it's something I want to reiterate again, based on what you just said, Amy. As far as that the whole term of statistical significance, really, what Amy said is correct. We want to be able to show progress over time. And that progress really, and what those targets are going to be is really up to you. I think we probably are just as interested in if you didn't make the progress that you're hoping to make, why? What were the barriers that you could potentially identify as saying, okay, well, listen, it wasn't this specific population, or we couldn't get to this population, or we couldn't get into this building, or our provider wasn't able to serve that population for whatever reason. And then what's the plan moving forward to then hopefully then make progress on that in the next year? And that'll be the opportunities that you're going to have in your annual update, your annual progress report, is to show us that. So show us the data. And if that did or did not meet your expectations as far as your target, why or why not? And then what are you hoping to do then in the coming year to be able to rectify and overcome those barriers, so you are making progress on that priority or that specific strategy, or moving that particular indicator one way or the other. So yes, we're not here to be punitive or judgmental on whether you are or not making your targets. What does that progress look like? If there isn't any progress, or that progress isn't as much as you would hope it to be, identify those barriers. And that's potentially data that we can bring back to the department. That if there's extra funding or special funding that comes in from the federal government, or we have targeted funding from the General Assembly, we have some of these things that we're already aware about, and then we can just make those funding decisions a lot more easier and a lot quicker to get those dollars out and to those who can use them the most. So it's that data collection, not necessarily the numbers. We served this, or we had a percentage decrease in that. Did you make progress? Is the progress satisfactory to what you want and your constituents and stakeholders need? And then if not, what are those barriers, and how do we eliminate those barriers so you can make progress moving forward? So it's all encompassing. It's not that number that we're going to look at and say, that's not what you said you were going to do. Now that's just not what this is all about. So this is a plan moving forward on how to progress your behavioral health infrastructure, how to improve it, how to introduce those services that are needed, and then how to sustain those services over time. This is a plan, and this is what we hope you be able to have conversations about with your stakeholders, your board, your constituents moving forward.
Thank you, Chad. So what questions are percolating out there? What trouble spots are you running into, or what things do you want to discuss?
And you can speak up, or you can use the chat. We'd love to see your face and hear your voice.
Hi.
Hello.
This may have already been discussed by someone else. I apologize. I was in another meeting that just let out. But one of the priorities that's set, I've just been trying to figure out how to get good data on, and that is the pregnant moms with SUD. And that money flowing directly from the state to the agency doesn't flow through the board. And so they're not required to give us data on it. So I'm I'm going to the agency and asking for that. I'm just not getting a quick response or a response. So what is the state's thought on that as far as that program? And one, it's something that the state has made it a priority. It's one that's been there in the past, and and we've always shown that we have the moms program that is addressing, that's our strategy, right? But we don't have the data.
Well, I think it's to what Amy and Haley said earlier in the recap is building those relationships. And so why aren't they sharing data? So is it a capacity issue on their end? Is it trying to make sure that they're playing well in the sandbox with others? I mean, we can kind of help you have that conversation. I mean, we had a lot of these conversations when we were collecting the crisis services data back in October. I mean, it's really around the same issue, access to data, having the providers provide you that data, that aggregated data and potentially disaggregated data based on populations or race or whatever. So we can help you kind of think through that, but it's really that relationship building. And if that is, and the board is reaching out and say, listen, we want to be able to kind of partner with this. We know that this is an important population. This is a required population for you and us. So let's kind of have this conversation and get access to this data. And we can help you have that. We can talk through some strategies for you moving forward.
Yeah, well, we have a good relationship with the agency, as far as, and we have routine meetings with the agency. But getting that information on this particular report, because of the money not flowing down from the state. So my last communication to them was because they sent me, I asked them what the mom's report looked like that they submit to the state. And looking at the categories, I see lots of areas that I could use to create a metric. And so my last communication to them was, they sent the report, but they said nothing in it. And they said, this information, we can't send it because it has, client information. And so I sent them this last one, sent them the guidelines from OhioMHAS for the community assessment plan, and I highlighted and circled and everything, all the things that are directly to this priority, and said, I need to create a metric around here. So if you just de-identify the information and get it to me ASAP, that would be great. Mm-hmm. And so, the next, our executive director to executive director meeting will occur next week, but I'm just getting a little anxious about this. So it'll be brought up in that next meeting. But I do want to make the state aware that this is very challenging when the money is not flowing through us and it's going directly to the agency. We're very limited on what we can demand. I see one of my counterparts here joining in on the discussion.
Yeah, I think just to reiterate for everyone, just make sure when you're requesting this data that you're saying you just want aggregate data, or just de-identify it. Like, you don't really want the raw data, right? Usually you just want to know, what is the percent that had this outcome, or what was the average, just aggregate data. And so if they try to say to you, oh no, it's protected client data, you are not asking for client data. So I know that's a big roadblock that often comes up. But a question for Chad, if in this situation, where basically it sounds like you've identified a good indicator, the data exists, you don't have the baseline data, and you're hopeful that eventually you're going to get the baseline data. So in that situation, Chad, would it be acceptable for them to say, like, this is the indicator, this is the data source, baseline coming soon, or something?
Yeah, we've had a couple of conversations with boards that are starting new programs or are starting new relationships with providers, potentially hospitals, to get access to data, and they just don't know what that baseline is. So it's perfectly okay to say baseline will be established by the end of 2023.
Okay.
Yep.
Chad, does that include, this is Phil Stone from Lucas County, does that include establishing the metric too? Because we had, for instance, we had RFP for the Latinx population, and we still haven't found somebody for that particular program. So we have no idea what we're going to collect at this point.
Yeah. Yeah, just inform us of that.
Thank you.
Yeah, just think about what is the outcome that you want to see, and just kind of say, like, what is that desired outcome? And then the work of the specificity of the indicator, maybe, might need to come later, but.
Yeah, and if you need to update that moving into the next year, then you'll have the opportunity to do that with your annual progress report. So, and there's someone, Jennifer, that put in the chat too, in response to pregnant women with SUD, that they reached out to their county WIC, their Women, Infants, and Children program, to get some information about the clients they screen that are identified as having SUD, and are working to establish a relationship with that agency to see where we can help with outreach, education, referrals, et cetera. So that could be another possibility as far as reach out. So Sherry, with your specific question, let me know offline how that meeting goes next week. And then if there isn't any progress made, we can kind of talk through like kind of next steps.
Thanks.
Chad, this is Robin. We have the same agency and the same problem with the MOMS program. They're saying that because of HIPAA, they can't provide us that information. To me, a program that's being funded by OhioMHAS and the board is asking for information, there should be some directive from OhioMHAS saying that it's appropriate to share with us. I don't get that. It's the same thing with Ohio Start. Looking at services we're offering to parents with substance use disorders, who have children in the system. And it's the same kind of thing. We don't get that information. And it's just a problem that we run into when programs are direct funded from OhioMHAS down to agencies. And I mean, let's be frank about it. In the current environment, it's very difficult for us to ask agencies for information.
What is the indicator that you want to get at?
We were trying to establish, around the MOMS program, what I was asking for was, what are they currently collecting and reporting, so that whatever we would decide to choose as an indicator would not put an extra burden on them.
Nice.
So
yeah,
that's what I was at, so that I didn't develop an indicator that required them to collect something they weren't already collecting.
Beautiful. Yeah, that's a great way to build a relationship, and will increase your likelihood of getting data. And I think it might also help to like give them, sometimes I call it like an empty table or a table shell, that just shows, like, we just want to know, as an example, maybe you want to know treatment retention rate for women enrolled in MOMS. How many stayed in treatment for at least 6 months or something? I'm just making things up here.
Yeah.
And so you would literally just show them a table that was just like, number of women enrolled in MOMS, number who retained treatment for 6 or more months, it's the percent, like, just like really showing them that all you're asking for is aggregate data. You don't want them to send you, this specific person was this and this specific, because HIPAA does not apply to de-identified aggregate data. They can't use that.
And boards are covered entities anyway.
So keep me updated on those conversations, and I will see what we can do on our end to kind of ease whatever tension may be. So I'm not going to promise anything, but I'll see what we can do on our end as far as at least trying to kind of grease the wheels a little bit to have that conversation. But thank you for bringing that up. I've had the same conversation with a few other boards on the other special population about dependent parents with dependent children, and potentially we've had the conversation of working with your PCSA to get access to the number of families that they see that are at risk. Again, de-identified data. I mean, no necessarily data that's going to identify anyone that is involved, but they track those numbers as well. So it's those relationships. So those special populations, again, those are sent to us by SAMHSA. Those are two populations that we need to serve through community behavioral health. But we're still in this process of this cap. Again, trying to work through the barriers and the hiccups and getting access to that data.
Well, the parents with SUD with dependent children is a little easier because we have system of care that flows through us, and we gather the data for that in GFMS and apply for it annually. So we have that information available to us if we're doing the system of care. The real issue comes when it's direct money from the state to the provider, and it becomes more challenging. But anyway, not to beat a dead horse, so we can move on.
So there's another question that came up in the chat.
I'm asking about the assessment.
So data requests made to OhioMHAS is the expectation that these will be filled in the next 2 weeks. These are specific to post-discharge HEDIS measures, engagement rates, requiring Medicaid data to accurately calculate. So what was it, last month, my colleague Craig Knudsen was on, and when you make those requests, just indicate that what it's for and the time frame that you're hoping to be able to get that information, and we will do our very best to be able to meet that timeline. So question number 9, references service gaps and access challenges for various groups, including general community program. What is the definition of this term? Possible examples?
That question 9. I'm not seeing a question 9 on the assessment or the plan template.
Vigorously searching. I think, Dennis, maybe that you're looking at the survey, not the template, and so the numbers are different.
Okay.
So can you help us find those questions?
Yeah, it's actually under disparities right at the beginning of the plan.
Okay.
So it's under mental health and addiction challenges, and then it starts to go into the disparities. So we're well along and pretty close to being finished, but we're just kind of going back through, and we don't want to leave anybody out. So we were just thinking how that could be utilized. Is that a disparity for us? We've identified other disparities and we're speaking to that, but we just weren't sure how that was used. It just says based on the assessment findings, which special population groups are experiencing the worst outcomes in your community for mental health and addiction challenges. So yeah, it's early on. So
it's a disparity option.
There you go.
Yes.
You got it.
Yes. Yes.
So it's the second one from the end there, general community program. So we were just wondering if anybody had an idea, if anybody had selected that and kind of what they thought that would reference.
Chad, I'm not remembering where that came from. I feel like that was maybe added later in the process.
That I can't say.
And we really don't have to spend a whole lot of time because we have identified other disparities. We just want to make sure, like, if it is something that we should be.
If it's not meaningful to you, Dennis, I wouldn't select it.
Okay. Well, that's what we did. We didn't select it, but then we're like, well, what does that mean? So figured I would ask. And then my other question was related to number 173, which is near the very end of the plan. So describe any child service needs resulting from finalized dispute with county FCFCs. So just how, just a little more clarification, I guess, on that, kind of what you would be looking for there. We've answered it. We just weren't really feeling like, I don't know, 100% on our answer.
So I can answer that one. So with question 173, if the board was tasked with anything in a dispute resolution process through the County Family and Children First Councils. So a family wasn't satisfied with what service coordination looked like or wraparound, the progress wasn't made, or they're not getting access to something that they feel they need to be accessed, being able to access, they file a dispute resolution process through the County Family and Children First Council. If through that process, the board was tasked or identified to then provide a service or make an arrangement to access services or identify a provider to provide a specific service, if the board was tasked to do something, please include that information in question 173. And then what the result of that was, or any ongoing tasks that the board could be identified as providing with that singular dispute within the Family and Children First Council service coordination system.
Okay, that's what we thought, and that's
Yep.
how we answered it. Just wanted to make sure. Thank you very much.
You're welcome.
What other questions are percolating?
Questions, or in the spirit of peer-to-peer sharing, is there anything that you're really excited about? Any data source that you've maybe discovered that you're excited about, or
Have a really great SMART objective that you want to pass along?
bragging is okay. Or has anyone found a great kind of opportunity for collaboration with their local health department or another partner, like finding a common indicator that you're going to focus on? You guys are going to be quiet.
And that's
All right, well, so
okay.
with that, and I know that we have a larger group, I forget, there's like maybe 50 some of us in this meeting. So we can handle this the way that we handle our office hour meetings. If there aren't any formal questions, I will stop the recording. We will end this kind of public session of this, and we'll leave the last 10 or 12 minutes or so, and just as a smaller group, kind of talk through any issues that you have. So if you're shy about speaking in front, or there are no dumb questions, there are no stupid questions, but if you feel more comfortable talking in a smaller group setting, we will provide you with that opportunity. So if there are no formal questions for Amy or Haley that you want to have on the record, I will stop this recording, and then we will stay on for the next 11 minutes or plus if we need to, and answer any questions that you may have. So last call for questions. So just a reminder, I know all of you know, January 31st, these are due. I have questions come in every day. I have another set of phone calls that are scheduled for tomorrow and early next week. So if you have any questions at any time about any particular section of the CAP, a specific question on a specific question, please just reach out, let me know, and we'll be more than happy to answer that question for you. All right, folks, thank you. Have a great rest of your day. Have a great rest of your week. I'm going to stop the recording. Again, if you want to stick around, please feel free to do so. Have a great day, everyone.
Thanks,
Thank you.
everyone.
Thank you.